The Indian College of Anesthesiologists, ICA, is a professional academic organization of qualified anesthetists of India or Indian origin. Ever since we started our webinar series from July 15, 2020, all Wednesdays, 7 p.m. Indian time, ICA webinar has been conducted, and we appreciate your support for our academic initiative. Now we are switching to CleanUp digital platform for hosting our Wednesday webinars.
Now, I would like to ask Dr. Radhakrishnan to please come over and give his kind words.
Thank you. Thank you. Good evening, all my friends, wherever you are. You are welcome to our webinar of the Wednesday, and we are signing into the webinar, which is for a change on clinical anesthesia. For the last two sessions, we were slightly outside the clinical anesthesia and we were doing something related to anesthesia. Today, we own clinical anesthesia and we're discussing on lung surgery and anesthesia. Not all the parts of lung surgery, certain parts of lung surgery, as well as some future changes which could happen is going to be discussed. And from now onwards, well, our podcasting will be done by Clarinet. And today, Clarinet is anchored by Miss Richa, and you have seen her speaking to you all. And the day's webinar consists of 3 different lectures.
And
four different lectures. First lectures will be physiological as well as pharmacological optimization to be given by Minati as well as Pallavi. The third lecture will be on double lumen tubes,
anesthesia,
and history and till date, and what will be the future of the DLT which we are using. And the last one will be the future of lung surgery, probably gauging from what we are witnessing today. And the speakers, as I said, Minati, Pallavi, and our Gehdoo, as well as one overseas speaker, Dr. Sudhakar Subramani from Iowa City, USA. And today's moderators, you know them very well, Manjula Sarkar of Mumbai and Jyotsna Goswami of Calcutta. I request Manjula Sarkar to take over the webinar and start.
Pallavi.
Thank you, sir, for your kind introduction about me. Actually, this webinar topic was decided by Dr. Radhakrishnan only, and he wanted this topic to be discussed. As I'm going to introduce first speaker of the day, Dr. Minati Chaudhury. All anesthesiologists knows that anesthesia preparation starts from the physiological changes to pathological changes to anesthesia management and post-op care for the better outcome. So Dr. Minati Chaudhury is going to speak on the physiological optimization of the lung surgeries. She is Professor Cardiac Anesthesia at AIIMS, Delhi. And I know she's going to tell us how the physiological optimization helps for the lung surgeries. So I call upon Dr. Minati Chaudhury to speak on this topic.
Thank you, ma'am. Ma'am, you have to unshare your screen. I cannot share my screen.
No, now?
No.
Because
yes, now I can.
Yeah.
Is it visible?
Yes, it is visible.
Okay. So in the next couple of minutes, I am going to discuss what are the physiological preparation before the lung surgery. I have nothing to disclose. There are so many pharmacological agents are there, but while the physiological preparation is essential. So if you can see the lung surgery, the spectrum is very wide. It starts from the simple biopsy till lobectomy, pneumonectomy, and wedge resection. And when you see the approach, it can be a simple keyhole for the biopsy by video assisted, or extensive surgery like sternotomy and thoracotomy, especially if the patient has to undergo a surgery for any malignancy. Again, the indications are varied. It is from small infection like tuberculosis, bronchiectasis, till bullous emphysema, traumatic lung injury, hemoptysis, severe COPD, lung infarction, malignancy, and lung transplant. Lung transplant, we are not going to discuss because it itself is a very vast if the preparation is concerned. And most of the patient who has to undergo a lung resection surgery have some changes in the pulmonary bed, both in the alveoli and in the vasculature. And all these thing changes give rise to some kind of restrictive lung dysfunction or obstructive lung dysfunction. This is the first thing. Secondly, most of the patient with lung disease, they have other systemic effect if they are chronically ill, especially if even if it is a malignancy or infection like bronchiectasis or anything. So they may have anemia, cachexia, severe muscle dysfunction, especially the respiratory muscle dysfunction. It has also some cardiovascular effect. They may have some metabolic syndrome, especially obstructive sleep apnea is very, very common in patient who has to posted for the lung resection surgery. And because of all this effect, they have some kind of anxiety and depression. Apart from this, the comorbidities are always there. And we also should know what are the physiological changes happen post lung surgery, because this is also important during the period, how to prepare the patient so that this post-op dysfunction can be to a lesser extent, and patient will be more comfortable in the post-operative period and he can recover well. So there are a lot of factors contributing, and all these things they lead to change in all cardiopulmonary reserve. There is psychological trauma, again anxiety and depression post surgery, because the patient always think when he is going to recover. There is a lot of sleep disturbances due to several reasons. All these things delay the recovery of the patient. So post-op lung can be also have several problems like atelectasis, collapse, and all. So the basic, there is a lot of changes again in the pulmonary function with the surgery. There may be if the patient has to undergo a wedge resection or pneumonectomy or lobectomy, there is a lot of reduction in the lung volume. And there also, if extensive surgery, diaphragmatic dysfunction is there. All these things lead to gas exchange impairment, and there is respiratory depression, control of breathing is affected, and lung defense mechanism is also affected. There is delayed wound healing because of delayed cough reflex and mucociliary dysfunction, all these factors. So before going to the physiological preparation, one has to remember, especially the students has to remember the pulmonary function system mechanics, and also they have to remember what are the lung volume and the capacities. This is very, very important. So this is a systemic meta-analysis by Majon et al, and they have basically three factors they have considered, that is force expiratory volume and diffusion capacity for carbon monoxide and maximum oxygen utilization. These three are very, very important to evaluate the patient and prepare the patient for lobectomy or pneumonectomy, because all these values they decrease from the predicted value to a greater extent even if the patient is normal. So some investigation again is very important to know the systemic effect of the disease and the severity of the disease. Suppose the patient is having this kind of a lesion, so this secondary, if it is a long standing, may give rise to some cardiovascular dysfunction and some mass effect due to compression of the adjacent structure. So for all these things, and this also cause secondary pulmonary respiratory function impairment. For all these things, one has to go for certain extra investigation. But what is most important for pulmonary preparation is first is the spirometry, next the diffusing capacity, and third is the predicted lung function. These three are very, very important. So what is the predicted lung function? Basically, the post-operative lung function, predicted post-operative lung function value is calculated from the pre-operative value. So both the lungs are divided into 42 segments in total. The left lung, the upper and lower lobe 10 segment, that is 20, and the right side is next 12 lobe, 12 segment, upper, middle, and lower lobe. So these lobes, functional capacity of these lobes are important basically to calculate the post-operative predicted FEV1. If the post-operative FEV1 is equivalent to the pre-operative FEV1 multiplied by 1 minus the number of functional lung segment which has to be removed, divided by the total functional lung segment. Suppose the patient FEV1 initial predictor is 70%. So 70 multiplied by 1 minus, that is suppose 14% lung is removed, so 14 by 12, that is a total lung segment. So 1 minus 1 by 3, so 70 multiplied by 1 divided by 3, so almost 33% will be the post-operative predicted lung volume. So if this is FEV1 predicted post-operative more than 40%, the patient is at a lower risks after the pneumonectomy or wedge resection, whatever. And if it comes to 30 to 40%, they come in moderate risks, and if it is less than 30%, that they are coming in the high risk category. So the patient who comes in the low risk category, they don't need much of physiological rehabilitation, but it is always important to go for physiological rehabilitation. But it is much more important the patient who are in the moderate and high risk category, they will get maximum benefit from this preparation. Second, cardiopulmonary reserve also, if the patient is having some functional impairment in the cardiopulmonary system, especially the obese and long-standing COPD, or a patient is having CAD, then the simple most important test is VO2 maximum, that is the maximum oxygen utilization. If it is more than 15 ml per kg, then that means less risks. So anything less than 15 ml per kg should be addressed, should be prepared physiologically. Then again, lung parenchymal function, that is the diffusion capacity of the lung for the carbon monoxide, and this is the post predicted value should be more than 40% to get a good result. In that case, you don't need much of preparation, but if it is less than 40%, yes, you need a physiological preparation of the lung. So this is the chart how to go about the preparation. So what kind of preparation you want to go for? One is the cardiopulmonary preparation, then quit smoking, then emotional, because patient is has to undergo a big surgery, they are with lot of anxiety and depression. Nutrition, of course, is a very important thing you have to address, and how to deal with the post-op pain and any sleep disturbances, how to tackle. And most important is again the patient education about the entire procedure, drain and wound care. Some people are very apprehensive in the presence of chest drain and all, so they have to previously educate about that. So who are the people has to be involved? They are the anesthesiologist, the surgeon, the physician, the respiratory therapist or the pulmonologist, the physiotherapist. So the first come to the patient and caretaker education. This is very, very important because they have to convince first what the patient has to undergo, how big is the surgery, and what are the probable post-op complication, and how to tackle those complications, and what is their involvement. That is very, very important. So what are the benefit of the physiological preparation, so that they will cooperate with you while going for the physiological preparation, because most of these preparation they need lot of patient cooperation at the same time. Psychological preparation, it is very, very important because I can say it is all in my head. Most of the things they develop from anxiety, depression, lot of catecholamine changes from that, so that give rise to sleep disturbances, delayed recovery, and more of feeling of pain. So psychological preparation is a must to this patient. Next is very important, quit smoking. We all know what are the content of a cigarette and what are the health disturbances that can happen during due to cigarette smoking. So next is what is the ideal time to quit? I can say every day counts. So most of the literature, they say it is 4 to 6 weeks prior to surgery is very important, and that gives rise to a better outcome of this patient. So even if the patient stop within 12 hours, that can decrease lot of carbon monoxide load in the lungs. And in 12 to 24 hours, it improves the ciliary function. In 5 to 10 days, it improves the laryngeal and bronchial activity. And in 2 weeks, most of the patients' sputum volume become reduced or normal. And but one has to think that no abrupt withdrawal should be happen, because most of these patients nicotine this create the cough reflex, so that patient can remove out the secretion much easily. But if there is abrupt withdrawal, there is no nicotine, that inhibit the cough reflex and cause retention of the secretion. So withdrawal should be gradual. And some patients, they have a lot of craving for nicotine. In that case, electronic cigarettes are available, even if they have some health effect, but because the nicotine content is much less, so one can advise that also. If the patient cannot quit cigarette for quite some time, so this can be advisable. So there are a lot of literature available how smoking quit reduce the mortality, morbidity, and improve the lung function, even if there is short-term smoking cessation. So you have to provide some educational material for the patient, but most of the patient, they are not so easy to convince to quit smoking all of a sudden. So you have to assist them for that, and you have to tell them why, what are the advantage to quit, and when they should start it, and what they should do, and how can you help them. So this is very, very important. So you have to make a plan and provide a skill and make a rapport with them, and then gradually quit the smoking. So next is how to improve the lung function. There are several methods, starting from simple coughing till percussion, incentive spirometry, and respiratory muscle exercise training. So coughing in this case, mostly you ask the patient to have upright position, then inhale slowly and deeply, then with a small grunting noise with mouth slightly open, and this maneuver usually loosen the mucous material, then you can take out the material. But if some patient they have a lot of weakness in the inspiratory and expiratory muscle, in that case you have to apply an abdominal bounder. So this coughing exercise, gradually they improve the respiratory muscle strength and improve the ventilation to lower lobe. This is very important for the recovery. Next is removal of the secretion. For this, you have to hydrate the patient repeatedly, and their postural drainage, adopt a different posture, especially lateral decubitus position frequently. Nebulization, in fact, percussion also helps to a greater extent to remove the secretion in the preoperative period, so that there will be less of atelectasis even with the remnant of the lung, and there will be better cardiopulmonary recovery. Then you have to optimize the comorbid condition at the same time. Incentive spirometry is very useful yet. If the patient can cooperate, you can go for it during the preoperative period. And the main purpose is to take a sustained slow deep breath to produce natural sighing breath. That should be mimic natural sigh, in which what the patient does, it is done with a spirometer, which can be volume regulated or flow regulated. And they are asked to take maximal inspiration, which should be slow, and from the FRC up to the total lung capacity, and followed by 5 to 6 second breath hold. Then remove the lips from the mouthpiece and exhale naturally. And how much to do? It is 500 ml per workout, each workout, and 10 incentive breath per hour. So that is good enough for the recovery. Then some people who are dependent on oxygen, you can attach a nasal cannula. Some spirometer available, you can fit the nasal cannula for oxygen delivery. And this is seen that it prevent and reverse atelectasis when used appropriately and regularly. But do all patients need it? No. Then to whom? Mostly you can obtain a baseline value also, so that you can analyze how much the patient is going down in the post-op period. That is one thing. Next is some patient, they have more pulmonary atelectasis and some predisposing factor for pulmonary atelectasis, especially if the patient has to have a prolonged bed rest in the post-operative period, if there is extensive surgery, And you cannot do pain control in a better way. You cannot give opioid and all like a patient with sleep apnea. And if the inspiratory capacity is less than 2.5 liters. So these are the cases in which it is better health the incentive spirometry rather than on regular case. So in general, it improves the inhaled lung volume, it prevents the lung injury after surgery, and it improves the sputum expectoration. But you have to be really careful, and there should not be no incentive spirometry in case if the patient is not compliant, and you have to supervise them. If there's a huge bullous emphysema, in this case barotrauma can happen and can rupture. If patient is having hyperventilation and uncontrolled hypertension, if there is hemoptysis and patient cannot take a deep breath, and if there is nausea and vomiting, in these cases you should not go for incentive spirometry. And again, you cannot use spirometry as a sole treatment for the major collapse and consolidation. In this case, you have to add other medication, which my next speaker is going to say about. And you have to take special precaution if there is small pneumothorax and small hemoptysis, irregular hemoptysis is there. And with care, you can go for this. And there is development of bronchospasm in some patient because of the hyperreactive airway in incentive spirometry. So there are many evidences that it helps in physiological preparation of the lung. Second is lung recruitment maneuver. This is basically done to open up the collapse alveoli so that there will be better oxygenation. But before that, you have to treat the infection at the same time or before time. In spontaneously breathing patient, how it is done, remove the mucus plug and keep the patient in frequent prone position. These are the things. And if the patient suppose it's getting mechanically ventilated in the ICU and for some time, then you do sustained inflation, that is the PEEP and different kind of ventilation, high frequency, airway pressure release, sigh, prone positioning. All these things are done for the lung recruitment maneuver. And mainly it open up the alveoli in the dependent part so that be lot of area will be available for the gas exchange. There will improve lung compliance and decrease pulmonary sound. All this thing improve the lung function before the patient is put up for the surgery, so that there will be better recovery in the post-op period as such. So, but it has a small term benefit, and because of the PEEP and all, especially when the patient is mechanically ventilated, there is hypotension and desaturation, and there is incidence of barotrauma at the same time. And what is again important, patient with sleep apnea, they need special precaution, because these are the patients who behave very notoriously in the post-op period. So some patients, they are not identified. So if the patient is very obese, then and the history of snoring, just go for a simple test, that is a nocturnal oximetry. If there is more than 5 desaturation event per hour, that means this patient will have more than 15% incidence of pulmonary complication than the usual, like the other patient who is undergoing a pulmonary resection. So in these cases can be prepared with nasal CPAP or BiPAP if possible in the preoperative period, and that has to be started in the immediately post-op period as well when the patient is extubated. And patient has to be trained for that, and he has to be educated for that. Next is respiratory muscle training, and you can go for both inspiratory and expiratory muscle training, both for the overload and improve the endurance. It is usually done by a trainer and twice a day, and there is a machine like this is available which is called power breath breathing training. And this is very beneficial if the patient is doing it 2 to 4 weeks before surgery, especially if the patient is having associated COPD. So this has been seen to improve the muscle fatigue in a very great way and improve the breathing pattern. And again, important, improve the metabolic function by improving the lactate turnover, and it stabilizes the heart rate and improve the oxygen kinetic. But however, you should not use this method and respiratory muscle training with this power meter if the patient is having spontaneous pneumothorax, or if there is any condition affecting the eardrum, if there is unstable asthma. And you have to again take precaution if the patient is having CAD, because this patient cannot strain so much, and if there is acute exacerbation of the chest infection. And also you should not share this equipment. Deep breathing, this is also very important. We all know what is the advantage of the deep breathing. Ask the patient to breathe through the nose as deeply as possible. Then ask them to hold the breath for the 5 to 10 seconds. Then breathe out through the mouth slowly and completely. And all of us know the benefit are enormous. It expand the lung and improve the secretion and distribute the air to all the area. So if done 3 to 4 times per day in the each setting for 10 to 15 breath, and it helps the patient in the post pulmonary resection recovery to a great extent. But however, you should not advise this deep breathing if the patient is having increase in intracranial pressure, any neck injury, hemoptysis, bronchopleural fistula, flail chest, and if on anticoagulation or recent heart attack. In these cases, patients should not have deep breathing, because all these conditions will be precipitated more, and the patient will landed up in more hazardous situation than the benefit of the deep breathing. So these are a few of physiological preparation of the lung before pulmonary surgery, and there are plenty of articles, meta-analysis are available, and all of them are saying that preoperative respiratory preparation benefit a patient to a great extent when the cardiorespiratory recovery is a concern. Again, important is pre-op nutrition should not be ignored. Patient should not be cachexic. If the patient is marasmic or cachexic, then the recovery again, muscle strength will not gain. So some advise immunonutrition drink and some carbohydrate loading drink just before the night before surgery. Some says multi-species probiotic you can give. So all these things have shown they improve the post-op recovery, even if they have certain complication. Obesity control is again very important, and patient, if there is time, ask them to reduce the weight to BMI should be less than 27, so for a better recovery. So this is again very important, and you have to continue include, even if you have given them the preliminary education and anxiety relief and all, but the continuous education and psychological support should be continued throughout the period of exercise and pre-operative preparation physiologically while you are doing. And this can be done with the verbal instruction, written material, audiovisual aid, and web-based aid, and this will give a better recovery of the patient. Thank you so much for the listening. And this is yesterday's picture on front of my road near my house. Thank you again.
So, thank you, Dr. Minati. It was a very nice, informative talk. And so we know many things about the physiological optimization now. So next will be pharmacological optimization. And as we all know that over 40% of patients with lung cancer, they have different kind of comorbidities like bronchial asthma, COPD, collapse consultation, etc., and which is associated with almost threefold increase in the postoperative complication. So our next speaker is Dr. Pallavi Waghalkar. She is the Associate Professor in GS Medical College and KEM Hospital, Mumbai, and she will speak on pharmacological optimization for lung surgeries. Dr. Pallavi, please.
And I request all the speakers to please spend time, because otherwise the webinar will not be completed. Sorry, but we have to pick.
Thank you, madam. And thank you, ICA, for giving me this opportunity. I'll be sharing my screen now. That is my CV, and I'll be talking about pharmacological optimization of the lung surgeries. Principles of optimization for lung surgeries I've divided into the small mnemonic, which is saline, which S is smoking cessation, airway dilatation, loosening and removing secretions, infection control, nutritional improvement, and education and motivation. Now, small words about smoking cessation, as Minati madam has already discussed. It's a single most important intervention in the perioperative period for avoiding the post-op complication. If the quit time is more than 8 weeks, the incidence of post-op complications are about reduced to 14.5%. I'll skip this slide because it's already covered in first lecture, that if the beneficial effect of smoking cessation, if we stop the smoking cessation like 1 to 2 weeks, then there is a decreased sputum production. And if you stop within 12 to 24 hours, then there is decreased carbon monoxide and nicotine levels. If it is more than within 3 days or 76 hours, then carboxyhemoglobin levels are normalized and ciliary functions are improved. So at least 1 to 2 weeks abstinence should be there. Just a word about smoking cessation. It is therapy includes behavioral changes, which include 5 A's, which is A, ask for tobacco use, advise to stop smoking, assess willingness to quit, and assist with quit plan, and arrange for follow-up. It also includes, now my lecture is about pharmacological therapy, so I thought of including some pharmacological methods, first line therapies, which is nicotine replacement therapy, psychotropics like sustained release bupropion, and varenicline, which is a partial nicotine receptor agonist. Now, nicotine replacement therapy, we have to be cautious because patients with underlying cardiovascular disease, recent MI, serious arrhythmias, and serious and worsening angina, this should be, used under medical supervisions. The drugs which is also used is bupropion, which is the mechanism. It's a non-competitive antagonist of nicotinic acetylcholine receptor. It might contribute to the effective smoking cessation. It has mechanism of action as an atypical antidepressant thought to affect the level of various brain neurotransmitters, dopamine, norepinephrine. So it will decrease the craving for cigarettes and symptoms of nicotine withdrawal. But again, the cautious thing about it, it can cause seizures, patients with history of cranial trauma, patient taking other antipsychotic medications, liver and kidney disorders. This drug should be cautiously used. The another smoking cessation pharmacotherapy is varenicline, which is Chantix by Pfizer. This is a non-nicotine cessation, partial nicotine receptor agonist available in oral formulation. It binds with the high affinity and selectivity at the alpha-4 beta-2 neuronal nicotinic acetylcholine receptors, and also it decreases the clinical symptoms of nicotine withdrawal. FDA has advised clinicians to monitor the patients due to reports of varenicline possibly associated with suicidal thoughts, aggressive erratic behavior, and excessive drowsiness. So they can also have a behavioral changes. Then next is A, which is airway dilatation. The topic will include control of bronchomotor tone, the drugs, and I have not included the AKT because it's a vast topic. The guidelines for the treatment of asthma, which are GINA guidelines, guidelines for treatment of COPD, which are GOLD guidelines. The word about therapy in idiopathic pulmonary fibrosis and bronchiectasis. So as we all know, the bronchomotor tone has control by autonomic nervous system. First is like sympathetic control beta-2 receptors on bronchial smooth muscles, which cause bronchodilation. And parasympathetic control, mainly they have a effect on the vasculature, airway vasculature, which has the muscarinic M3 receptors. The activation by acetylcholine will cause bronchoconstriction. And inflammation is also another important factor which controls the bronchomotor tone. So this is like effective of autonomic transmitters on the airway. Parasympathetic system stimulation will cause the bronchial smooth muscle contraction and increase mucus secretion, while sympathetic like beta-2 receptors, which will cause the bronchodilation. This is just a figure from a book which shows the role of beta agonist, which is acts on the adenyl. It will activate the adenyl cyclase enzyme. ATP is converted to cyclic AMP. Cyclic AMP is the main responsible factor for the bronchodilation. Cyclic AMP gets converted to the inactive form where the phosphodiesterase enzyme takes action. So these phosphodiesterase inhibitors in turn will cause the bronchodilation. This is a role of inflammation and chemical mediators for the bronchospasm. Because if at any time the mast cell gets sensitized with the exposure to the antigen, and the mast cell, if there is a repeated exposure to the same antigen, then mast cell degranulation will occur, which will release the chemical mediators, which will in turn will cause the different bronchoconstriction mechanism, and there'll be bronchospasm. So basically, pharmacotherapy of this diseases will include the drugs which will act on this all these steps, where we can use a mast cell stabilizer, which are chromogylate, or leukotriene synthesis inhibitors, which are corticosteroids, leukotriene receptor antagonist like montelukast, or bronchodilators like salbutamol, ipratropium, or theophylline. So these are the list of the various drugs which are used. First is bronchodilators, beta agonists, methylxanthines, anticholinergic, leukotriene antagonist, mast cell stabilizers, corticosteroid, which can be systemic and inhalational, anti-Ig antibodies, antihistaminics, mucolytics, and decongestants for the cough for antitussives and expectorates. We should remember the pharmacotherapy of asthma will include the short-term relievers, which are for immediate reversal of bronchospasm, but not effective in underlying inflammation. So these are mainly used in acute attacks, which are short-acting beta-2 agonists, anticholinergic, and methylxanthines. While long-term controllers are controlling the degree of inflammation, and they're bringing out the improvement of overall asthma control, which are taken on regular basis, like inhaled corticosteroids or long-acting beta-2 agonists, leukotriene modifiers, or methylxanthines. GINA, Global Initiative of Asthma, has given this guideline in which are revised in 2021, and they have given this algorithms for asthma treatment for adults, children. These algorithms are available online. They give this flow chart, and they have divided the treatment into assess, adjust, and review. We have to assess the patient, adjust the doses of the drug, and review the patient. They have also given the treatment of asthma into two steps. There are this is a referred reliever and a controller. So they mainly include the inhaled corticosteroid or formoterol as a therapy for as a reliever, relieving of the exacerbation, while the controller, that means the regular use for controlling the infection, they have used this inhaled corticosteroid formoterol. If the patient is not getting relief, they have added LABA, that is long acting beta agonist. And if like the stepwise approach has been given. So step 2 will be, they will add first inhaled corticosteroid. If patient is not getting relief, then they can add into LABA, that is long acting beta 2 agonist, or then inhaled corticosteroid and then a long acting beta agonist with leukotriene receptor agonist. This is the stepwise approach, which is freely available online. These are the GINA guidelines. The guidelines for COPD treatment has been revised, and these are by Global Initiative for COPD, GOLD guidelines, which includes basically the diagnosis is based on the presence of symptoms and airflow obstruction demonstrated by Bose bronchodilator, FEV1 to FVC ratio of less than 0.7 on spirometry. So they have given this classification of airflow limitation severity in COPD, which is based on Bose bronchodilator FEV1. So gold one will be the mild degree, where the FEV1 is more than 80%, and gold 4 will be this very severe COPD, where FEV1 is less than 30%. They have also given some charts which have been, these are the questionnaires for patient, which is modified British Medical Research Council dyspnea scale, where the patient answers about his breathlessness and grades the breathlessness. There is another questionnaire which is CAT assessment questionnaire, where patient answers whether I'm feeling very sad, like a pain, Vasco grade the pain. The patient grades his symptoms. So they have given this refined ABCD assessment tool, where spirometrically confirmed diagnosis of COPD, assessment of airflow limitation, and assessment of symptoms and exacerbation. By giving that, as we said, it is graded from gold 1 to gold 4. And for therapy, they have given this ABCD approach. So A patients will be the this MMRC and CAT questionnaire they have included. Low risk patient are A patient, more symptoms and low risk patients are B patient. Very few symptoms, but there are high risk are C patients, and more symptoms and more high risk patients are D patients. And according to this, they have given the therapies, initial pharmacological treatment, as we see that less severe patient will only have a bronchodilator, while the more severe patient will have all the long-acting muscarinic antagonists, inhaled corticosteroids, and long-acting beta agonists, that is LABA. they have also basically the COPD choice of initial therapy of patients in group D who are symptomatic and severe at risk of exacerbation depend upon the intensity of symptoms, and also they have included the word about eosinophil count, the circulating biomarker, to help guideline treatment choices to maximize benefit and minimize the risk of inhaled corticosteroid therapy. They have also given the relationship between the blood eosinophil count and likely benefits. So this is a chart they have included where the factors to consider when initiating the inhaled corticosteroid treatment. And they strongly support that whenever there is history of hospitalization, exacerbation, more than 2 moderate exacerbations of COPD per year, and blood eosinophil count is more than 300 cells per microreal, they strongly support the inhaled corticosteroid therapy. While if there are report, because inhaled corticosteroid therapy itself has its side effects, it can lead to pneumonia itself. So if there is repeated pneumonia events, if the blood eosinophil counts are low, there is history of mycobacterial infections, then there is a weak support for inhaled corticosteroid therapy by GOLD. So these are the adverse effects by inhaled corticosteroid therapy, like oral candidiasis, hoarseness of voice, adrenal suppressions, increases risk of cataracts. For preoperatively or perioperatively, the recommendations for starting the steroid therapy is like, if this, again, the patient surgery is minor, moderate, or major. If it is a major surgery, then we can give dose preoperatively 100 milligram hydrocortisone at the induction, and then 100 milligram IV TDS for 2 to 3 days. The gold criteria was also include the following: how to follow up with pharmacological treatment, and like if there are exacerbations with and patient is on LABA or LAMA, then they have said that whether LABA plus inhaled corticosteroid or the triple therapy with LABA, LAMA, or inhaled corticosteroids, if it is not useful, then they can add the, in former smokers, they have also advised azithromycin. And if FEV1 is less than 50% or chronic bronchitis patient, they have also added roflumilast, that is leukotriene antagonist. In PCOPD patient, it's a multisystemic disorders. We should also remember that it can lead to pulmonary hypertension, the right ventricular enlargement is secondary to any cardiac or pulmonary disease. So the patient might be on this core pulmonary, for the core pulmonary, he must be on some medication which should be continued. Patient might be on long-term oxygen therapy, vasodilator treatment, diuretics, or digitalis. So generally these drugs are continued perioperatively. Long-term oxygen therapy guidelines, they have given that if the PaO2 is more than 60 and SaO2 is more than 90, that is the target we have to keep, PaO2 of more than 60 and SaO2 of more than 90. So indications will be absolutely whenever the PaO2 is less than 55 or SaO2 is less than 88, then the patient might be on this long-term oxygen therapy. Pharmacotherapy in COPD, the gold criteria has also included the influenza and the pneumococcal vaccines for the COPD patients, which should be given perioperatively. COPD gold criteria also includes COVID-19 criteria, and they have given exactly like according to the severity of the COVID-19, they have given the different therapeutic and investigations to be done. Guidelines has been given. So as the topic about COVID comes, we all know that patients we have come across with COVID with idiopathic pulmonary fibrosis, which is also a known interstitial lung disease. Interstitial lung disease can be fibrotic or non-fibrotic. So fibrotic patients can come for lung transplant or malignancy resection. Non-fibrotic patients are only because of autoimmune disorders which require steroid therapy. So the idiopathic pulmonary fibrosis is a chronic progressive fibrosing condition, progressive, irreversible, and lethal disease. So treatment of idiopathic pulmonary fibrosis, the traditional treatment included prednisolone, azathioprine, N-acetylcysteine, or warfarin. But new era anti-proliferative therapy includes pirfenidone and nintedanib. The perioperative use of pirfenidone, and there are different studies. We have also seen patients on pirfenidone. There are studies with reduced risk of postoperative severe respiratory complication with pirfenidone. Basically, it is anti-fibrotic drug, which is molecular target is unclear, which is active in several animal models on other organs also, like liver, kidney. So it is anti-fibrotic drug. It's FDA approved, and its dosage is like there are 3 to 67 milligram capsules 3 times daily with the food they had given. Basically, for anesthetists, we should consider that before starting or pirfenidone, the liver function test and renal function test should be checked, because there are some warnings and precautions. They might cause elevated liver enzymes, it might cause photosensitivity rash, it also can cause gastrointestinal disorders. The nintedanib is also triple kinase inhibitors, phosphatase activator, which is anti-angiogenic and anti-tumor activity. FDA approved, indicated in the treatment of idiopathic pulmonary fibrosis. Its dosage is 150 milligram twice daily, and approximately 12 hours apart can be given. But again, nintedanib, again, it has many warnings and precautions. As an anesthetist, we should consider that liver functions and renal function test should be done. It also has some arterial thromboembolic events reported. So use cautions with the CAD patients, cardiovascular risk patients. Also, there are reports with bleeding events with the use of nintedanib. After L, this is after A comes loosening and removing of secretions. We know that facilitation of mucus clearance is important for lung surgery, providing adequate hydration by fluid intake orally or IV, removing the causative factors, optimizing the tracheobronchial clearance, use muculitis, and reduce the inflammation. So then comes the disease of bronchiectasis. As we know, is an abnormal permanent of dilatation bronchi. And in bronchiectasis, what happens is enlargement of bronchi in their disease, decreased ability to clear the secretions. So failure to clear the secretion will allow the microbes and particles to collect in them, and that in turns will lead to more secretions, more inflammation, and then there is a vicious cycle. So good bronchial hygiene is very important perioperatively. Pharmacotherapy of bronchotaxis includes antibiotic therapy, bronchial hygiene, bronchodilator therapy, anti-inflammatory therapy, adjunct surgical resection, or lung transplantation. So how bronchial hygiene is maintained? By postural drainage, as madam has already discussed, and mucoactive drugs. Airway hydration is also important, which is mucoactive drugs like hyperosmolar agents or mucolytic drugs is the main therapy. The hyperosmolar agents mainly which is used in practice is hypertonic saline, dose 6 to 7% BID by nebulizer, and even this normal saline can be used for hydration therapy. Another drug which is used as a mucolytic is N-acetylcysteine, commonly used for treatment for bronchiectasis patient. It's a mucolytic agent which disrupts the disulfide bonds in the mucus when it is inhaled. And benefits of this agent may come from antioxidant properties. N-acetylcysteine also has antibacterial properties. But as we know, it is we should use with caution. N-acetylcysteine itself has a bad odor. It will lead to bronchospasm. So the patients should be on a bronchodilator therapy along with whenever they have been started with N-acetylcysteine. So monotherapy is not given because of its side effects. The mucolysis, as I already said, the inhaled form may cause increased bronchial secretions and bronchospasm. It might cause emesis. It has a very bad odor, disagreeable odor. Next comes is I, which is infection control, antibiotic therapy. If there are frequent exacerbations of COPD asthma, they are on regular antibiotic regimen. If there are infrequent exacerbations, then there are episodic oral antibiotics or episodic parenteral antibiotic therapy is given. So initially reducing during the acute phase, amoxicillin, trimethoprim, levofloxacin has been used. And in bronchiectasis, Pseudomonas is the organism, or then the oral quinolone parenteral therapy with aminoglycoside also has been given. There are aerosolized antibiotics are used, delivers relatively high concentrations of drug with relatively lesser systemic side effects of antibiotic, beneficial in treating the Pseudomonas. Colistin and gentamicin has also been used. Next comes N, as madam has already discussed. Nutrition is a very important factor for reducing the post-operative complication, because less nutrition, malnutrition will cause reduced ability to fight with infection, impaired wound healing, longer hospital stays, muscle wasting, which will have reduced ability to do usual activity, impaired temperature regulation, micronutrient deficiency. There has been this paper on the role of nutrition support for postoperative recovery of respiratory function in patients with primary lung cancers, where they have followed up 182 patients of lung cancers with a 1-year follow-up, showed the patients with malnutrition and general diet, and with the nutritional support patients showed decreased mortality and better outcome. E for education and motivation has been already discussed in detail by madam. As like patients should be educated and motivated to all this chest physiotherapy and incentive spirometry. So summary for pharmacological optimization, preoperative preparation needs to be explained to the patient in particular that they should be like what could be the risk and benefits of the post-thoracotomy pain management strategies. Pre-medication should be light in this patient because of hypoxia and respiratory depression. Patient undergoing thoracic surgery are prone to develop post-operative respiratory complication and therefore advisable to do pre-operative preparation efforts to optimize any pre-existing pulmonary disease. All these patients should undergo following steps like first of all smoking cessation, airway dilatation with inhaled beta-2 agonist, ipratropium bromide, especially in COPD, steroids, either inhaled or IV, that will improve the PFTs. Loosening and removing the secretion. The secretions should be loosened out by adequate hydration using humidifier or ultrasonic nebulization. Secretions are then removed by postural drainage, cuffing, chest percussions, vibrations for 15-20 minutes several times a day, chest physiotherapy, and post-expiration techniques. Control of infection, if present, should be treated by antibiotics according to culture and sensitivity, and measures to increase motivation and postoperative care like nutritional improvement, weight reduction in obese, psychological preparation, instructions about incentives, spirometry, chest physiotherapy, and postural drainage should be given. These are my references. Thank you.
Thanks, Pallavi, for elaborative pharmacological optimization of the lung surgery patients in detail. Can you unshare your screen, please? Pallavi, can you unshare your screen, please?
Yes, ma'am.
Yeah, question answers are going to be taken after the whole session. And our next speaker of the day is Dr. R P Gehdoo. Dr. Gehdoo doesn't need any introduction. He is internationally famous pain physician as known. He is working presently in D.Y. Patil Medical College as a professor in the Department of Anesthesia, but mainly dealing with all pain cases. Sir is going to tell us about the history of endobronchial tubes till date. All of us knows that endobronchial tubes are required for lung surgeries, very commonly used. Most of the cases are in need. Sir, over to you.
Yeah, am I audible now? Hello?
Yes, you are audible and you are visible. Your
Yes,
slides
that's
are
good.
very well. Yeah.
Good. So they actually, I should thank ICA also for giving me a historical topic to a history man. Thank you so much. So the topic given to me is endobronchial intubation, a history till date. It took me a lot of effort actually, but I could find out a lot of knowledgeable things, which really makes a huge difference. So let's begin with that, where if you see over here, now why this is not going further. It's not going further. Yeah. It begins with the word that is the further backward you can look, the further forward you are likely to see. This is being said by the Winston Churchill. Now, if you see, one lung anesthesia presents with many practical, anatomical, and physiological challenges to the anesthetists in the modern day practice. The techniques, the equipments that we use today have developed slowly over the course of the last century. And you will not believe that the idea of isolated lung ventilation came from the bronchospirometry studies by pioneer physiologists as much as 1871. And then thereafter, the original equipment came in 1932-33. So once the need of independent ventilation of the lungs was identified in the clinical practice, the pioneers of the techniques development and all those things started their own methods, and it has been now changed a lot. And this has led to the ability of the anesthetist to be able to control the ventilation of each lung, including the collapse of the operative lung or the complete lung or even the individual bronchopulmonary segment, and protect the isolated lung against all the chances of contamination or any other problems. And if you see this, the original, historically speaking, I don't know how this is going up. This cannot come down. The first double lumen tube used in the bronchospirometry, and later it was used for the one lung anesthesia in the human and was introduced by Carlens. And modification of these original Carlens tube have been introduced by the Dr. White, Robert Shaw, and others. And the most commonly used double lumen tube was Carlens and the Robert Shaw, as it is being shown down over here. Now, these are the historical dates that have been upcounting. If you can see, the one which are being marked red, that is right from 1931, where the first endotracheal tube was introduced into the bronchus. So it was a single lumen tube bronchus was done. Thereafter, in 1936, it was McGill's who contributed for the rubber one endobronchial blocker that was positioned for the endoscopy. And slowly, as you can go down, but the most important finding for this is, these are the important events that in 1950, it was Carlens who made it a double lumen catheter with two inbuilt curves, two cuffs, etc. And you can see the cross section also, which shows it was side by side in the horizontal plane, though both tubes were there. While in 1959, Bryce Smith, who made it vertically the plane in both the tubes. So thereafter, Bryce Smith, along with the Salt, introduced the right-sided tube. Earlier, it was a left-sided tube. Then in 1960, it was White who started the right-sided one. Then in 1962, Robert Shaw started both right as well as left. And that time, in the cross section, you see it was introduced as a D-shaped in the horizontal plane. Then in 1979, it was Burton, by the help of National Catheter Corporation, he started using the disposable Robert Shaw right and left DLT along with the low volume, high pressure cup, which is nowadays more not being used very popularly. Now, these are the first four scientists which are being involved as far as history is concerned. It starts from Ivan McGill, which was from 1888 to 1986. Then Eric Carlens, then Roger Smith, and Robert Shaw. These are the four scientists who are being involved. But if you see really history, which is a black and white one, this is the one truly an historical thing where the Edward Plugger and the Claude Barnard, they were the physicists who started studying the gas exchange, and they designed a simple catheter that was used originally for the dog. But thereafter, in Wolfberg was the one who started this using in 1871, whereby he used it as double lumen, endobronchial single lumen tube. And as you can see in the picture over here, where it was introduced through the tracheostomy tube also, while the other one was used using a bronchoscope. So these are the real historical ones. This has been published in 2017 in the Journal of Anesthesia History. After that came the normal double lumen tube, what we were using, that is by the Gate and Waters. He started with the endobronchial tube in 1932, which was basically molded by heating the rubber endotracheal tube in hot water and folding lateral curve to the left and right. As you can make out, the coronal cuff was the one which basically started sealing the other lung. This is the way it started using the endobronchial tube. So it used to be pushed in one of the lungs, and for the other one, it used to be inflated the cuff so that the other lung automatically gets blocked. This was the original one concept that has come. And then in Rovenstein in 1936, he started using endobronchial tubes with a woven silk and each tube was incorporated with two cuffs. This was the first one which was introduced as a tracheal as well as bronchial cuff. Thereby, we can isolate both the lungs separately. But only problem was this was so short and woven silk, so the suctioning was not very much possible. That was the only problem at that time. Then came Ivan Magill in 1936, who introduced the cuff endotracheal tube, which we have already been using. So it was left and right-sided tubes which was being used. Only thing in the right tube, what he did, he put a distal wire spiral so as to permit it to go into the right bronchus, right upper lobe bronchus, so that it can be ventilated easily. So that is what was his idea, but it didn't work very well. That's the reason it was not being used nowadays. Then came Eric Carlson in 1950, who introduced the double lumen tubes for the separation of the lungs. And he designed it basically from the bronchospirometry. And they were all made up of the red rubber catheter, which I'm sure all of us old people have used all these tubes, including the Carina hook tubes, that is the right sided, left sided. We always have used. So it had two lumens. They were oval shaped in the cross section. They were shaped automatically to pass into the left bronchus. Distal end had a cuff to seal the left lung. It also had a carinal hook. The above carinal hook opening for the ventilating right main bronchus, and above this was the tracheal cuff, as you can make out over here. So this was the tracheal cuff, and this was a carinal opening. I mean, there's the carinal hook, and here down here is your endobronchial cuff. So he inserted DLT under the topical anesthesia in the good old days in the sitting posture in 1949 and in 1950. That was originally done for removing the tubercular abscess, and then along with the jaw, he introduced for the lung dissections. Then came Roger Bryce Smith in 1959, who removed the carinal hook easily because that was the one which was troubling to put it, and it was also traumatizing. That is why he removed the carinal hook, and then he introduced the left-sided DLT without a carinal hook, which also had the two cuffs. There were two anterior-posterior placed tubes in the cross section, as I told you already, showed you earlier also. The tracheal tubes were put anteriorly and bronchial tube was posteriorly. So this was the thing which again created a problem that suctioning was again difficult because it was in the anterior-posterior direction. So if I want to put any suction catheter, even if it is a small size, into the endobronchial region, it was not possible for that. Then came Robert Shaw, who was a basically anesthetic plus substitution in 1962. He became the skilled in using Carlin's tube for the one lung anesthesia, and he realized many shortcomings, that is anatomical things and cost, construction, because it had a narrow lumen, so suction was not possible, plus hook. So he removed all those things, and thereafter he introduced the two semicircular D-shaped lumen side by side. That is how it becomes quite easy for us to do the suctioning also. And as you can see over here, the tube is being shown down over here. That is blue cuff, which was for the bronchial, and the red one was for the tracheal. And then, of course, it was a large bore, so suctioning was also easily possible. Plus, if we need, we can also pass the fiber optic bronchoscope, which was not done earlier. It was unforeseen at that time. Of course, thereafter, we now shift on to the endobronchial, because nowadays in many places, they are what the problem with the double lumen tube was, you basically has to sacrifice one lung completely. Suppose, for example, if I'm going to do a right upper lobectomy, I will have to put a left-sided double lumen tube. So I have to sacrifice the entire right lung. So that is how the endobronchial blockers came into the picture. And that is being much more used if I want to employ or use the remaining part of the recruit, the remaining part of the lungs also. That's the time the endobronchial blockers became much more popular. So these are the historical double lumen tubes. As you can see, this is your Carlin's tube, this is Robert Shaw tube, and this was the right Robert Shaw tube. And these were the lumens and hooks present or not. This is in details that have been given. So this was the carinal hook that was being shown to be putting exactly at the carina on the both the tubes. And this is the famous one, the Robert Shaw tube, which was the left-sided tube, as well as it was also having a right-sided tube, which was shown over here, which has got a hole so that which can ventilate the right upper lobe. Now come to the bronchial blocker. These are the blockers that have been coming slowly day by day, and there are a lot of newer things that have been coming up. That is a Univent bronchial blocker, and then Cohen, Copdec, Easy blocker. This is a newer addition. Then Fusy blocker, Fogarty, of course, has been used earlier, even for the pediatric patient. And now that has come out a balloon tip, and one more that has come later on, that is Vivo 1. So if you see, Univent was introduced in 1984. Here, it was a single lumen endotracheal tube, basically with a small separate lumen containing a non-latex type of bronchial blocker, which has been shown at the tip over here. So it was designed to block either the left or the right lung to enable one lung ventilation, and can be used for selective lobar blockade also, because I can push the endobronchial blocker much more further, so that suppose I want to block only the right lower lobe, I can do that also, or I want to block the left upper lobe, I can do that also by proper manipulating, and thereafter also passing the fiber optic scope so that I can make out that where exactly it is been going. And then it enabled the lung isolation even in the patient of a difficult airway or even tracheostomy. That was the thing. He started with a Univent. So Univent is basically going through the endotracheal tube. Then came Ernst blocker, which actually had a loop over here. As you can see, here is a loop which was present at the tip. So this loop is used to connect the catheter to a flexible fiber optic scope, so that under the fiber optic scope, we can guide through the loop the location of the endobronchial blocker at the right place wherever we want to block. For example, any right upper lobe or right lower lobe or left upper, left middle lobe. So how to place an unblocker? The optimal position of the unblocker is in the left or in the right bronchus is achieved when the blocker balloon the outer surface is seen with a fiber optic bronchoscope at least 5 millimeter below the tracheal carina. And thereafter it is being targeted further and a proper seal is being obtained. And then we remove the fiber optic. So this was the loop one. Then came the Cupdeck one, which was basically a multi-port type of adapter it had. And another advantage it had was it also had a distal end of 20 degrees angle was there, so that it's easier for me to manipulate from outside only. I can manipulate if I want to go on the left side or I want to go on to the right side of the bronchus. So it is very easy for us to manipulate with that. Next came Easy Blocker, which is the latest one that has come in the market also. Easy Blocker, of course, is very, as the name suggests, easy. It's very easy to insert this blocker. And the beauty is it sits exactly onto the carina over here, as it has been shown. But the only problem is it is something very much close to our double lumen tube, because even if I inflate one cuff, it will basically block the entire left or the right, whichever one I am inflating. That was the only problem with this, but otherwise this has been very easy to insert. It doesn't have any chances of misplacement and all. Plus it has got a radio opaque shaft, so which can be visible under the X-ray. So I can take a image intensifier or a CM also, and I can make out where exactly it's been this Easy Blocker placed. Sorry, that was Cohen. This is Cupdeck now. So this is the one which has got a multiple adapter multi-port adapter, and plus it also has got a wheel-controlled deflecting mechanism. So this is the one which will control from the remote area, that is outside the endotracheal tube also. I can just control, I can just rotate this, and I can push my endobronchial blocker into the right, left, or whichever direction I want to go. So that also can be done, and that can be used along with fiber optic endoscope also, so that I can make out how it is going, where it is going. This type of flexi tip blocker also is selected as a favorable lung separation device in certain situations like difficult intubations, because it is not easy for us to push the tube, a double lumen tube into the right direction, whichever way I want, or an emergency lung separation, or even in the pediatric cases where you can see the internal diameter is just 1.6 millimeter. Then came, this is the one which one here you can make out that the blockers that have been used it's used for one lung ventilation that can be achieved by placement of a blocker to either right or left lung and to the separation. And here, this is the one which can be preferred in the pediatric size one. So you can see that the size is available at 4.5 French or even for adult 9 French. And it has got a fixed hockey stick type of the guide at the tip. So it can be guided very easily. And it has got also a largest working channel of 3 millimeter. So even a smaller fiber optic scope also can be passed. And it also has got a suction catheter in between. So because at the tip, if I want to suck out, right, rather if there is any secretion in the operated to be lung, that also I can suck out. Or if I want to deflate that, collapse that lung, I can also suck out the air also from that. So that is the beauty of this one. Then these are the one which are being very commonly used one, where we can see the single lumen balloon tip catheter, which is, it doesn't need any other, it's a Fogarty one, which has been very popularly used earlier also for some other purpose. That is, it has been used for the removal of the bladder stone and all those things also, or rather ureteric stone. So this also can be used, but the advantage of this is it's very small size, so it can be used even in the children. But only problem is it doesn't have a accessory lumen also. So even if I want to suction out or if I want to give a small CPAP, it's not been possible in this case. That's the only thing. And plus it has been made up of the latex allergy. So that also has to be patient with allergy. It cannot be used. Last, and this is the beauty one that has come at the very late, that is called Vivosite endobronchial blocker. It consists of a steerable balloon tip catheter, and the catheter can be visualized. Here there is a small camera that has been installed over here. This is a single lumen tube that was used earlier. Now it has also come with a double lumen tube, where here is the site for the camera. So through this, you can monitor also where exactly you don't need a fiber optic scope thereafter to push it inside. So when the catheter is being, sorry, this bronchial blocker is being pushed, we can really monitor where exactly it is going by looking at the camera over here, so that you don't need any aid of fiber optic bronchoscope. So this is the latest one that has come out, which has got a high resolution video imaging camera at the tip of the blocker for single lumen. And for double lumen, it is just before, after the tracheal cuff. This is the one. It can be insertion, can be done under vision. So we don't need a bronchoscope also. So this is the one which is the very latest one. Thank you very much.
Thank you, Dr. Gehdoo. It's a very exhaustive and nice history. We got to know so many things what was before. Actually, we also had used the RDS endobronchial tube, and now we are seeing the Vivosite also in our practice. So it is a long history, and it is nicely described. Thank you very much.
Thank you.
So please stop sharing your screen. Yeah. Okay, so after this physiological and pharmacological optimization, then we have learned the devices. And now our next speaker will be Dr. Sudhakar Subramani, and he is the clinical associate professor in University of Iowa, USA. And he will speak on the most practical, our day-to-day practice, that is the current scenario of anesthesia for lung surgeries and its future. So over to Dr. Sudhakar Subramani.
Thank you for ICA, and then Dr. Manjula, especially, she contacted me. So with the short notice, I was able to put some of the information. So the topic which I'm going to talk for the next 20 to 30 minutes is about the current scenario of what we are doing for lung surgeries, and then what we are going to expect in near future. So I'm just going to, nothing to disclose relevant to the talk. So at the end of the sessions, I'm hoping the participants will able to understand what the current practice, especially the folks who are not doing the thoracic anesthesia frequently, and then to understand some of the fundamentals behind why the ERS protocol has been promoted in this thoracic surgery, and what are the challenges we face when we are implementing those. And then in the end, I'm going to touch upon, what are the expanding role of interventional bronchoscopies, how anesthetic services will be helpful in those remote locations. So First of all, I would like to emphasize, one of the key things to be keep in mind for a successful thoracic program. You may have to list few things. So we have gone through sessions earlier about like emphasizing on understanding the various the endobronchial tubes, and then make sure that you have a wide range of tubes available, so you don't know when you're going to need one over the other. Obviously, we need to have a pediatric training on the fiber optic scopes, and then you can do this as simulation trainings when we don't have that options of doing it in the real patients. And I'm sure most of us are familiar with the thoracic epidurals and paravertebral blocks, and there are other regional techniques have been expanding in this surgery, so that training program has to be emphasized. And of course, the the team, the person who have done enough of this should be readily available to give an expert input. So those are the things we should keep in mind, and then periodic internal review to make the program more successful. When it comes to one lung ventilation, there are a few things we can keep in mind when you are controlling. So obviously we should try to maintain as much as possible to keep the peak airway pressure around 35 centimeters of water. And then if you have this plateau pressures somewhere around 25, so you have to put an external effort to try to do these two important measures to minimize the lung injuries. And of course, you can optimize the PEEP based on the underlying the conditions, especially with somebody with pretty bad COPD, you have to be very careful in titrating. I know most of the monitors will have the ability to watch those various spirometry parameters, and then you can titrate on that. And then ultimately our goal is to maintain the carbon dioxide level as near as normal as possible. And some situations it's very impossible to keep that, so mild hypercarbia as is allows to the patient's situation. So those are the things you should keep in mind whenever you are using the one lung ventilation. So historically, all the procedures started with the open thoracotomy as like any other surgical specialty. But then minimally invasive is being promoted for the last, at least for the last couple of decades. And there is no difference even for thoracic surgery. We all know that the VATS has been expanding. So these are the few potential procedures which they can be able to do through the video-assisted thoracoscopy. So the common procedures is obviously with the segmentectomies or lobectomies. You can do some wedge resections, decortications, and some of the lung volume reductions. There have been reports of the pneumonectomy, but it's not there yet, but there are a few centers that are able to do it. So focusing on the pneumonectomy, which still thoracotomy is the primary approach in many centers. So even in high volume centers, they try to do video assisted or using the robotics, but they're mostly of case serious at this level. And if they end up in doing, they would rather use multiportal access. The challenge is whenever they do video assisted scopes for pneumonectomy is like variability in their practice, whether they have to work on artery versus the vein, if we have a catastrophic bleeding, how we are going to handle with the limited access, and also the extent of lymph node dissection. So those factors play a significant role when it comes to determining the type of surgical procedures in pertaining to the pneumonectomy. So the next couple of minutes, I'm going to talk about the influence of the anesthetic techniques. Whether the intravenous versus the inhalational, is there one over the other having any good benefits on that? There are many studies looked into this early 90s. So the group from Toronto, they tried to do it, mixing of both intravenous and the inhalational within the same patient. But then ultimately it was very challenged to do even for ethical purpose. So this is one of the study I would like to quote where it was a small number, even though it's like, 30 patients, but they went into very extensive analysis. And then they tried to compare between the propofol versus the desflurane in this case. And then look at this at the various time periods. So what are the markers they used? It's pretty commonly used, the inflammatory markers, like, you can name it like interleukin 6, 8, TNF alpha, whatever contributing for acute lung injury. So that's where they were focusing on. And then they look at the various time period, as I mentioned, immediately before the one lung ventilation, at the time of one lung ventilation, and then 2 hours after the procedure is done. As you can see, most of the markers is in favor of desflurane. It has its own unique benefit of, bronchodilator properties, less effect on hypoxic pulmonary vasoconstriction. So those are the theories they proposed. And overall, this is in favor of inhalational agent. But when you look at the meta-analysis, which was recently published, so this group, they only able to manage to get only the AI trials, even though initial screening, they were able to get hundreds of the report. But ultimately, most of them are not well validated, or they have not done a decent amount of analysis. So they narrowed down to 8 trials, which was close to 500 patients. And the same things they were trying to compare and see propofol versus the sevoflurane, and you can have any differences in the dependent lung as well as the operating lung. So in this particular slide, you can see the common markers, interleukin 6, and then the interleukin 8, where you can see slightly in favor of sevoflurane, especially the immediate post-op, but eventually after 2 hours, there was no significant difference in terms of the markers. In terms of the operating lung, we also try to look at the various parameters like 6, 8, and TNF alpha, all in favor of sevoflurane. So I believe most of the centers, we are favoring more of inhalational at this moment. And then the theory of inhibition of HPV become very negligible. So at this time, I think the inhalational is the common technique practice pretty much in many centers. So by knowing the type of the anesthetic technique, next thing come to your mind is your the mode of ventilation. So historically, individuals, we started doing more of a conventional, 8 to 10 ml per kilo, the kind of what we try to do even with the one lung. But then they started realizing there are more injuries. Was there any data on it? Even though the study was published like more than 15 years ago, they tried to look specifically at the various time parameters, like similar to what we saw between TIVA and inhalational, before, at the time of one lung, and then the 2 hours after the post-op. Again, in favor of whenever you do a low tidal volume, which is like anywhere between 4 to 5 ml per kilo when you're down to one lung versus the 10 ml per kilo when you are in one lung. So historically, the markers were pretty much significant on the higher volumes groups compared to the low volume. Although after 2 hours, the difference become very negligible, except what they noticed, the icon, one of the main mediator that purports the lymphocytic proliferations and then potential lung injuries, which shows consistently even low after a few hours after this, the mode of interventions. So I think after this, the paper, and then looking at the many variables, most of the locations, it's more of a low volume technique. So you can stick on to 4 to 5 ml per kilo whenever you try to do a one lung ventilation. Rather than the volume, you also keep in mind something it's coming up is the driving pressure, which we try to understand. The anesthesiologist, whoever manage the intensive care settings, lot of newer ventilators will have the ability to directly give those number in a real-time scenario. But if you don't have that, you can always calculate based on the difference between the plateau and the peak pressure, which is nothing but the tidal volume changes over the compliance of the system. So this there is one study which is a small 60 patients in a randomized trial. What they try to do is they try to implement the PEEP either in the incremental fashion versus the decremental fashion. And then they've tried to see, is there any way there's a difference we noticed in terms of the markers of the lung injuries? So what they observed was, yes, overall, by targeting the driving pressure in an acceptable range, which is overall helping for minimizing the lung injury. But what more? Yes, obviously it's in favor of more of a decremental rather than the incremental. So like this, all the plain ones are all is the decremental ones. You know, if you start with the high PEEP, like anywhere between 12 to 14, and then you gradually you decrease as you watch the driving pressure. And they also noticed the overall the driving pressure requirements were pretty low whenever you use this the decremental technique compared to the incremental technique. So by knowing the modes and then as well as the type of anesthetic technique, next thing come to your mind is the type of monitoring. You know, most of our patients, obviously you can start with the regular blood pressure cuff and you have other AS standard monitors. And then if you're anticipating major bleeding or anything more than segmentectomy, then there is a possibility you always have to put an arterial line for a close monitoring. But what I'm going to emphasize is even more advanced cases which having a comorbidities, you know, what type of monitors you would like to need. So obviously one of the things come to your mind is the Swan-Ganz catheter, which is pretty commonly used, although there's a declining trend even in the cardiac populations. But there are certain situations where you may need to consider in a high-risk thoracic surgeries who are having a significant amount of moderate to severe pulmonary hypertension. So it's much helpful to determine, you know, whether what type of pulmonary vasodilators you want to use. You know, you may have to use it from the time of beginning of the inductions. And then you also need to know what is underlying the RV functional status. So there are many factors that can help to, you know, carefully manage those high-risk patients. So there is a potentially role, although the numbers are pretty less, but you should consider it in placing this the Swan-Ganz in certain high-risk patients. The next thing is obviously the echo, which has been rapidly growing even in non-cardiac anesthesiologists. So the focus on focus is what been promoted by many institutions, and then with the thanks to the technologies improved, the simulation centers were widely available. So many anesthesiologists compared to 10 years ago are pretty much comfortable in doing certain limited transthoracic views. So I would emphasize on learning those skills whenever you are dealing with these high-risk patients will definitely save you a day. So even if you don't want to do many views, at least keep this minimum views where you can focus on comparing the RV versus the LV apical four chamber, you know, subcostal views, as well as if you want to do like a parasternal and then parasternal short on the long axis. These are the limited views. There is also extended views, but at least to begin with, you can learn some limited views, and once you get familiarized, you can expand. Why it is very important, and similar to what I mentioned for the Swan-Ganz, you do end up in developing like certain patients with potential moderate to severe pulmonary hypertension. The RV is going to compromise. So it's always have the habit of just to quickly scan prior to induction will help you whether we need to start inotropes upfront on board or even pulmonary vasodilators with the induction. Because once the RV fails, it's so hard to recover. And then, you know, especially in those challenging situations. And other things is dynamics keeps changing when you are spontaneous to controlled ventilation. So many things can change in a drastically at the peri-induction period, which is the very vulnerable period for high-risk patients. So let's keep in mind. So continue to learn and then try to apply this technique. Then in addition to the Swan-Ganz and the echo, the non-invasive cardiac output monitoring. I'm sure most of you are familiar with in the market. There are many techniques are available, and then monitors been upgrading. There are challenges, you know, they try to improvise on their, you know, the techniques to capture those in a broad range of pathologies. But whenever you try to use this, you have to keep in mind certain things can change physiologically that can alter the number, and then you may end up in managing in a pretty wrong way. So you have to be very experienced before that when you try to use in one lung. So you should have been well versed in using it in abdominal cases, or especially the colorectal cases, before you try to use it in the thoracic. Challenges here is the thoracic patients prone for arrhythmias, and then also open lung when the even with thoracotomy of the VATS, physiology is changing, the stroke volume variation might alter. So there's not enough data at this moment, unfortunately. Mostly the case series are the limited randomized trials, not like a large size. So those are the challenges we are facing at this moment. But in certain high-risk patients, I would recommend to use it from the beginning and then try to see, have a baseline before you position the patient, and then you see how things changes with the VATS or the thoracotomy and so on. So yeah, always keep this in mind whenever you're using this, the non-invasive monitoring. I know the previous speaker, the professor, has mentioned various tubes. So one of the tubes where you have the ability where you can even measure the cardiac output. This is called like an ECOM tube. We have both single lumen and the double lumen tubes are available in the market. In our centers, we used it for a few cases. Then we did like a pilot trial, and then encountered like some challenges, but of course it's helpful whenever in certain high-risk patients. One of the challenges we realized was this artery influences, because you're so close to the cardiac structures and the aortic, the ascending part of the aorta, where you may see this impedance kind of keep interferences. Although the newer version, they say that they're better put on optimizing those interferences, but we still encountered in a critical step. But whenever we use this, you get some limited data on stroke volume variations. And if we input the central venous pressure, it automatically calculates the vascular resistance. So those information might be helpful for you to titrate the inotropes versus the vasopressors. The way it works is, if you can see here, there are like certain, the transducers, which is like an impedance method. If some of you are familiar, we used to do this impedance method on externally, but with the open chest, those are the challenges, but that is what they are trying to overcome by doing it directly impregnated on the cuffs. So the only thing is you need to align along the ascending the part of the aorta. So in that way, you can able to expect that stroke volume derived from this method. So those are the challenges whenever we use this tube. So aligned along the ascending part of the aorta, and then you get the Doppler flow that will help you to calculate the stroke volume. So whenever we use this non-invasive or any kind of methods where we can able to do the stroke volume, then it's always helpful for titrating your fluid status, right? So this like thoracic, we are pretty judicious in administering the volume. So we have to be very, very cautious on it, especially when the resection is getting more and more. Veg, most of the time we can get away, or a minimal resection. But when it comes to major lobe or pneumonectomy especially, you have to be very cautious when you're administering the fluid, because once the pneumonectomy is done, you don't want to push the cardiac circulating volume into the one lung and causing some significant pulmonary edema. So that is why the fluid titration is very essential in certain patient population. Same thing, this is one group of study where they try to look into this, patients who are having esophagectomy through the transthoracic approach. They try to compare the goal-directed versus the conventional way of fluid therapy. And ultimately, they found out that whenever we use certain modules, you are basically trying to minimize the, the overall immediate complications. For example, like anastomotic leak or re-explorations, those kind of things. So then followed up for a period of a month. And as you can see, this goal-directed therapy overall will have a less complication compared to the conventional way of fluid therapy. If you want me to take one slide, this is a very important slide you can watch, especially for the trainees who've been managing these critical situations. one of the most common complications you will encounter in lung isolation is the hypoxia. So how we are going to troubleshoot? You can apply your fundamentals like what you do in the 2-lung. Always check the basic things, machine to man. You make sure that you're not missing any of those connections, ventilation is adequate, and then you can increase the FiO2 to temporarily to 100% until you buy some time. So that is the first step I would like to do it. And once you exclude any mechanical causes with your fiber optic assessment, then you can always go and start improving on recruiting the ventilating lung, like clearing the secretions, optimizing the volume versus the rate. And then, as I mentioned earlier, the PEEPs, those things is going to helpful. So once you maximize your ventilator settings on the ventilating lung, then you go and disturb the operating lung, because you try, the ultimate goal why we are doing 1 lung is for the surgical exposure. So you try to delay disturbing the operating lung as much as possible. So most of the time, if you do the basic steps along with your cardiac output, the things will be taken care. Of course, we are going to see in certain situations where we have a bilateral significant lung disorders, especially the post-tuberculosis, bronchiectasis, those patients are really high risk to ventilate. And those populations, we may need to have to use certain additional measures. For example, like, you can use a CPAP or intermittent jet ventilations on the operating lung. So basically CPAP, you are giving an 100% oxygen. That's going to be helpful for diffusion oxygenation, and also it will reduce the significant amount of shunt by pushing the blood back to the ventilating lung. Very rarely you need specific pulmonary vasodilators on the ventilating lung. Down the road, if you still ran out of all these options, ultimately you are going to ask the surgical team, either you clamp the PA temporarily, which is kind of a challenging step. They're not going to be comfortable unless you are doing like a pneumonectomy, but most of the time we compromise and we do like a intermittent 2-lung ventilation. Whenever it comes to the saturation, one of the things is how low is really low. One of the idea, it comes to be like, you have to apply your physiological knowledge. So ultimately what you are trying to do is the arterial oxygen content, right? So that's what at the tissue level. So if you're able to address the hemoglobin significantly, that's going to improve your first step in addition to your cardiac output. If somebody with a decent amount of cardiac output and satisfactory hemoglobin, the low saturations, they always tolerate, because the delivery and the saturation, it doesn't go very well as it's shown in this graph, where you may have a saturation of 100%, but then the tissue delivery is probably low and vice versa. So it's not a very good predictor of correlation. But when it comes to oxygen consumption, again, the delivery of the oxygen and the consumption of the oxygen is not always parallel. As you can see, up to a certain stage, it's kind of, correlates, but then it becomes like significantly dependent on the supply. So this is where the most of the time we are dealing with in a critical situations. So you optimize as much as possible to improve your tissue oxygenation. As I mentioned, with the growing techniques, I'm not going to talk about the epidural or the paravertebral, but some of the other regional techniques which is been expanding. The anesthesiologists who are doing heavily on the regional techniques, I'm sure they're familiar with this various surface blocks, which is like a PEC blocks, PEC 1 and 2, which is predominantly going to cover the upper part of the anterolateral thoracic segments. And then if you want to cover on the lower part of the anterolateral segments, you may have to do a serratus anterior block. And then more focusing on the medial, because some of the ports they may have to do pretty close to the sternum. Then they do a transplane blocks, which is similar to a tab block at the abdominal levels. You may do a transthoracic plane blocks. So these are the few options. You can use ultrasound guided in certain situations. And also the similar to the erector spinae block, which has been expanding in the cardiac populations. So there have been studies going, especially for the last 5-6 years, they tried to do it even for certain iris thoracic procedures too. This particular study, it's over 100 patients. They try to compare between the erector spinae and the intercostal block. And what they noticed is there was less change from the baseline in the pulmonary functional status, FEV1 or FVC, in the erectrospinal block compared to the intercostal block. It's kind of broad range. It covers us in a pretty wide segments, and also helpful for minimizing your pain score and then PACU stay, those kind of additional benefits. So it is relatively easy technique, then even in a high risk patients who are on anticoagulations, it's amenable if you weigh the risk over the benefits. So then move on to the other blocks, which is like, as I mentioned earlier, the intercostal. They try to compare between the conventional thoracic and paravertebral blocks. What we noticed is this, the intercostal blocks in favor for compared to the systemic, but when it comes to the paravertebral or the epidural, they are still popular techniques, which we all know it's reliable, and then we can keep the catheters, we can continue it for even for a days as compared to the single shot intercostals. In terms of the advanced part of this, it's one of the things is the robotic thing. So the robotic assisted has some challenges it poses, positional related, and they try to use some CO2 insufflation, which we don't routinely see in the VATS population. So that might cause some significant hemodynamic instability. And so close communication with the surgical team is very, very essential. And also you have to watch on what type of CO2 they are using it. There's a potential risk of hypothermia and so on. So those are the things, whenever you are dealing with this robotic assisted, may have some additional challenges. And we had a case where it's very refractory hypercarbia. In spite of all the maneuvers we did, patient ended up in having a delayed, they took almost few hours to resolve this hypercarbia. So much CO2 got absorbed and very, very hard to ventilate whenever you're dealing with the one lung ventilation. So the data on comparison between the RATs versus the VATs is what it's upcoming. A lot of studies being published, especially in the last couple of years. The main thing focusing on the operation time, which is comparable. It's like any other robotic techniques like prostatectomies or hysterectomies that people are learning. So I'm sure most of the centers is all in the early phase. So you may see a little bit long operating time. But this particular group, when they published, they saw that it is not much difference, especially the data from 2015 to 20. And same thing in terms of the blood loss, it's minimal compared to the VATs. And then in terms of the conversion rate, also it's comparable or slightly in favor of robotic. And then overall morbidity and mortality. So all is in favor of robotic, which has a better visualization. And then of course the learning curve, once it gets better, you may end up in seeing in the next decade more and more of robotic assisted thoracic surgeries. While on the robotic side, there is another side where you don't want to intubate and then you can still do the thoracic surgeries, which is kind of a challenging, but you need to be really, really an experienced surgeon with a limited access. When I say limited, it's just like a one port where you can do everything. You have a camera, you have, those scissors kind of controlling those the hemostasis, and everything has to be in the one port with a minimal incision. It is been expanding, as you can see that for the last 10 years, the growing number of this, although you see a conversion rate is also pretty stable, but I'm hoping like once they get expertise, you may see a less number of conversion rate on it. There are many exclusion criteria, which is relevant to us, uncooperative, challenge to put a regional techniques, and especially significant coagulopathic. When we are heavily depend on the regional techniques, this may not be an amenable option. The last part is about the ERS, which is like any other, like, when it started in the colorectal, the surgical committees were pushing forward, expanded to the other part of the surgical specialties. So you are seeing more and more data again for the last, I would say probably 5-6 years. This is one of the early guidelines, which was published in 2008 on involving the multidisciplinary approach. So as our previous speakers emphasizing on optimizing, that plays a very significant role, both pharmacological, non-pharmacological kind of optimization that covers all the spectrum here. But when it comes to intra, so understanding that whatever I mentioned earlier, using those, conventional mode of ventilations, and then driving pressures, for example, and then using certain non-invasive cardiac output monitors for titrating the fluid, plus your regional techniques, everything will add into this intraoperative phase ultimately. And then post-op, which is predominantly the surgeon's controls, but early removals, ambulations, and so on, you can expand that. But what guideline says that when they start implementing, there are some evidence in favor and some evidence which is still need more data on it. So the striking feature is the clear fluids. You don't want to keep them dehydrated in terms of the oral, not by giving in the IV form. So emphasize on the clear fluids until like 2 hours before. I don't know how practical in certain centers in India, but if you're able to do that, it is well and good. That's a good data in favor of the ERS protocol. And then intraoperative, we don't have any doubt on it, how important for the pain control, multimodal. All our patients invariably, they get Tylenol and then gabapentin, and then even sometimes the coxibs for certain patients, because we tend to see a lot of opioid dependent patients in our region. So that's kind of very emphasizing on how pain control is very essential on it. And then in terms of fluid therapy, as I mentioned that, you try to stick on to, limited fluid therapy and plus, the surgical techniques, which is like technically VATS or robotic is in favor of this thing. So ultimately what we are getting is the significant shorten the length of stay, which is like, even though it says 3 days, but then it's pretty significant in terms of cost benefit, plus overall, your morbidities, especially the immediate post-op, has been more in favor of when you implement it. But it needs a lot of workforce, starting from the pre-op preparation and stuff. There was a survey, which is interesting to see from UK when they published, even though it's kind of, the dynamic system there, NHS controls most of the services, we still have certain barriers to implement. There will be variation in the practice. So those things we need to be minimized. If you have a surgeon, 4 surgeons, they want to operate in 4 different ways, obviously that's going to put a lot of challenges from our aspect. So the uniformity is very essential for successful implementation of this ERS protocol. And of course, that a lot of, the additional services, your nursing assistants and everybody has to be helpful in certain therapies. So the COVID, which we have to live with it for a few more years. So at some point, everybody is going to take care of the COVID patients. So why it is very important when it comes to the lung isolations, you can see this list of situations where we are prone for high risk for aerosolization compared to any other case where you can quickly intubate and get away. But here you are constantly going to handling those secretions, checking the tubes intermittently, making sure that you're oxygenating well, adequately ventilating well. So which means you can't get away whenever you are doing the thoracic cases without exposing for pretty. So in addition to your routine precautionary measures, what you are doing, you have to put an effort. This is like the studies published and try to do it in a simulatory fashion where you have to have those extra measures whenever you are clamping and declamping those, switching those sizes or even placing those tubes. So just kind of an extra measure. So the last couple of minutes, I'm going to wrap up with certain bronchoscopic procedures, which is like, it's an expanding zone. It's more for a diagnostic as well as for the therapeutic purpose. As you can see, the list of the commonly performed, the limited diagnostic as well as certain advanced. When I say advanced, they try to do, certain biopsies like ultrasound guided biopsies were going on pretty extensively. If they have very, tricky area when the surgeon doesn't want to go and manipulate. So probably this may be a less invasive option if you want to sample, especially around the hilar regions, and having this impending mediastinal issues. So in terms of the therapeutic procedures, you may see broad range. You may have stent placements, cryoablations, or a lot of bronchial valves, especially for the lung volume reductions. It's been expanding. For the trainees, this is one of the high yield slide where you can see various flow patterns here. It's been tested in your boards, and also for if you have this ability to look at the flow meters, always I would emphasize at the beginning of the case, post-induction, you try to acquire these waveforms and see how the waveforms looks like before and after this intervention. So this is the classical form of, this is a normal waveform where you can start with the inspiration followed by expiration. If you are using positive pressure ventilation, it's going to be upside down. So just keep that in mind. And then for the variable extrathoracic obstruction, you're always going to see problem at the inspiration, and variable intrathoracic you're going to see in the expirations. When it is a fixed tracheal stenosis, it's going to be both phases going to see the obstruction. Restrictive pattern, all the volume is going to be less. So as you can see this, or in a COPD pattern, it's kind of a scoop pattern. So it's a few commonly described patterns. So just pay attention on those flow patterns. Techniques, common technique again is endotracheal tube is what widely used, but there are been reports where you can even use an LMA guided, they try to place for a minimal interventions, but if they are very extensive, I would recommend, especially with high risk of aspiration, better to stick on to the endotracheal tubes. In terms of mode of ventilations, you have to have some experience on jet because you don't know when he's going to require various options. You have a manual and as well as the automated jet ventilator options are available. The final thing is as I was telling earlier, this is one of the system called Chartist system. This actually helps to understand, whether the individual has the collaterals or not. For example, this is what normally you see when you start the catheter and then goes and occlude. And if you don't have a collaterals, you are going to see a declining plan. But if you have a collaterals, then obviously the lung volume is still been expanding from the neighbor zone. So that's what the pulmonologist will try to determine, is it worth doing the valves or not. So just to summarize, we reviewed what are the challenges we face for these lung surgeries, and then expanding role of many regional techniques, how the robotic is going to play in the next decade or so, how we have to prepare for that, and then what is the role as a perioperative physician for successful program for the ERS. Thank you for your patient listening.
Dr. Sudhakar, you have to unshare your screen. You have to unshare your screen. And I request all the panelists to be online. There are not many questions in the chat box, but one doctor wants to know that when we are keeping the high PEEP, then what happens to blood pressure and how we have to manage it?
That I have, ma'am, answered in the chat box only.
Okay. Now, I have few questions.
Manjula, they said probably the audience cannot see those answers, so she might as well tell them again.
Yeah, so please discuss again. You can say what was your answer in the chat box. Dr. Minati, you have to repeat your answer.
If you increase the PEEP, because there is an increase in the intrathoracic pressure, the blood pressure goes down. So if the patient can permit, you can manage with that fluid. Otherwise, you have to give the PEEP incrementally, not extremely high PEEP. You have to look for that.
What do you mean by high PEEP?
So that is somewhat more than 10. That was the book says.
So usually required PEEP is up to 4 to 5 to 6, and it should not reach more than 10. Now I have two questions to Dr. Sudhakar. Dr. Sudhakar, I want to know, do you keep the separate reading or separate ventilator settings for different lungs in the same patient?
Sorry, I was breaking. Can you please repeat?
Yeah, I want to know, do you keep the separate ventilator settings for different lung during the lung surgeries? Is it possible?
You mean to say after we convert it to one lung, like
Yeah.
when settings?
Yeah.
No, I don't think, to my knowledge, but I mean, obviously, what we are noticing is like, you have those spirometries, advanced spirometries, where it will be helpful to determine your vent settings. But I don't think, to my knowledge, maybe others can explain that, but yeah.
Anyway, excellent presentation by you, and you have given the really excellent overview of anesthesia management for lung surgery patients. So thank you very much for that. And I want to know one more thing from you, that how much fall in oxygen saturation you permit in a patient, and how much rise in EtCO2 is permissible when you are dealing with one lung ventilation from the base.
Yeah, that's a good question. So that's why I put that the relationship between the delivery and the oxygen consumption, right? So how low is too low is always the controversial. So you have to keep in mind other factors like anemia is one thing come to your mind, and then the comorbidities, what is the current coronary status, if there are any functional issues on the biventricular functions, those can play a significant role. Like somebody with, good function, young age, they can easily tolerate even like 80s for a while. And the downside for the, with the elder populations with those comorbidities, obviously, like, very limited rooms, we are at some point may cause some myocardial ischemic injuries as well as your cerebral saturation. So I'm not sure how popular the cerebral oxygen saturations we use in Indian population, but that is one thing we use in certain high risk people, just to know that you're not compromising too much. Because the reason why I'm telling is, whenever you have hypoxia, 100% there is always going to be hypercarbia. So there will be a blood, preferentially you are perfusing the brain. So most of the time, even though it's in hypoxia, the brain is still getting whatever the minimal amount of oxygen.
So the cerebral oxygen oximetry should be done in such kind of the patients as a routine monitoring?
No, I won't say it's a routine, but like as I said, if you already the comorbidities, and then there is a potential risk of long one lung isolations, and then especially post tuberculosis. I still remember during my training back in India in Jipmar, we had few cases, very, very refractory. We did all those measures, still you will be surprised the PCO2 was in the high 80s. So the patient was still alive. So some patients will be used to that, but the challenge is, as I said, if you have this ability, you can at least ensuring that your cerebral oxygen is kind of preserved. Yeah. In terms of high carbon dioxide, it's the same rule, right? As long as the pulmonary vascular resistance is kind of handling, your RV is handling, I think it's okay for allowing for permissive hypercarbia. So most of the time I've seen around 55 to 60 range. Okay. Not even in one lung. We do this robotic prostatectomies with very high BMIs, 60, 70 BMIs. Those patients are hard to ventilate. Forget about the one lung, they are even worse to ventilate. And then we have seen 75, 80 PCO2. So intermittently we have to stop them and then try to optimize and then restart. That is, we have done few cases, but unfortunately we can't do that in the one lung, but yeah.
And in your practice, would you extubate all your patients on table, or would you like to keep in ICU for some time prophylactically?
You mean we may, yes, probably I would say 1 to 2% where we may have to go to ICU, but most of the pneumonectomies will go to ICU just for the other reasons. And then pneumonectomies, they want us to extubate as much as possible. So that's why the regional techniques are very essential. I don't see any reasons for not extubating in those patients. Yeah, I mean, of course, we're talking about the regular ones, not like the transplants, right? That's a separate group. Yeah.
Okay, and there is one more question. How do you give CPAP to non-ventilated lung to treat intra-hypoxemia?
Yeah, I mean, I think it should be readily available like any other, it's like a transport bag we can use. It's like a Mapleson C system. And if you have the ability of having those CPAP dial numbers, basically you have to connect to an auxiliary oxygen port, which is basically your 100% oxygen. And typically we start at the lowest number possible, like even 2 or 3 CPAP. As I was mentioning, physiological reasons, 2 things are happening. First and foremost is your diffusion oxygenation. Because since you are giving 100% oxygen, you are diffusing into this. Yes, you are going to compromise some vasoconstriction, which is favorable for you. But more important is you are giving this positive pressure where you are pushing the blood again back into the ventilating lung. So those are the 2 physiological things will help eventually.
Thank you very much. I thank Dr. Minati for telling us about the physiological optimization. It really helped in thoracic surgeries. Pharmacological optimization by Dr. Pallavi. She has really given the excellent talk on that and how we have to do and how it's going to help us. Dr. Gehdoo, as usual, history till date, all the endobronchial groups he has already discussed. And I know that endobronchial blockers are commonly used nowadays at most of the centers, and it really helps us. And as the future is very bright for the thoracic surgery, we are moving towards robotic surgeries, and we are doing video-assisted thoracosurgeries also. So really, Sudhakar has done the excellent job in short time and very good presentation. Dr. Sudhakar, really thanks. And now Dr. Baljit Singh will take over. Anyone else wants to say anything?
Would Jyotsna like to say anything before we conclude?
Wants to say anything?
No, madam, it's all the speakers has done excellent job, and it's a short of time, and everybody has done that quite justice on the topics. So I think now it should get it. You should take it over this thing.
Yeah. So thank you very much. Dr. Manjula has very nicely thanked all the speakers, Minati, Pallavi, Dr. Gehdoo, and Dr. Sudhakar for their excellent talks. And I like this prehabilitation that we have introduced, which is so important in all surgeries. And that has been very well covered in this webinar. And all the topics, as Manjula said, were very, very well covered. And it is only the moderators now who are left to be praised. Thank you so much, Manjula. And thank you, Jyotsna, for moderating this webinar so well. So it was a very nicely conducted webinar, and the students, leave alone the students, even we consultants, faculty have learned a lot. Thank you so much, and see you all next week. Thank you, Sanish. I think we can, would you like to show the next week's webinar? Project
Thank you, Jayashree, Manjula. Thank you very much.
Thanks
Jyotsna.
a lot.
Thank you so much.
And this is the next week.
Thank you, Manju madam.
This
Thank
week.
you, Jayashree madam.
Yeah. Thank you. Thanks a lot. Thank you very much.
Bye, everybody.
Thank you.
Bye-bye.
Good night.
Bye-bye, good night.
Good night.
This is the next week's program, Anesthesia and Eco-Friendly Environment. And we would be looking forward to this webinar. Thank you very much. Bye-bye.
Bye. Good night.
Bye.
Good night, everybody.
Bye.
Good
Good
night.
night. Good night.
Thank you so much, all of the doctors who have attended today's session. And with this, I would like to conclude the session for today. Have a good night, sir.